cannabis. In addition to having acted as Chief Medical Officer at Zenabis, one of the largest licensed producers of medical and recreational cannabis in the country, he is a renowned surgeon, entrepreneur, and an advisor to large pharmaceutical companies. He is also the holder of several patents for medical devices designed to treat chronic pain and an in-demand speaker and educator. With a specialized background in cannabis and pain management, he is passionate about contributing to new methods, approaches, and insights into the way we treat patients both today and in the future. He is partner involved with eHealth Global Block Certs, Emerging Healthcare Models, and Technology Canada. He is a urological surgeon at several hospitals in British Columbia and is currently serving a large practice of patients through his growing medical cannabis pain management practice. As a lover of research, he has authored many papers in peer-reviewed journals on the topic of aging and cancer, cancer detection methods, and cell biology processes. For this, he has been awarded with numerous awards and honors from the American Urological Association, Canadian Cancer Society, Natural Sciences and Engineering Research Council of Canada, and Medical Research Council of Canada. He is presently involved in cannabis research for migraines, overactive bladder, and pelvic pain. He is involved as an investigator in several phase 3 and 4 clinical trials in the cannabis and urological sciences spaces. So please give a round of applause for Dr. Mohamedali.
Thank you very much, Holly. All right. So that work out. Hold it over. Okay. That looks good.
Point.
Yeah. All right. How are you guys doing? Excellent. Thank you very much for the warm invitation today. So I'm going to spend the next little while talking a little bit about two very big topic areas. But I've kind of shaved the prostate cancer part of it down a bit because you have a lot of great speakers that come here quite often and give you some great insight into the management of this disease and a lot of aspects of the prostate cancer disease. The one thing that you probably don't get exposed to as much is the use of cannabinoids, of cannabis, in cancer care or in care, cannabis use in general. So I'm going to try and focus a little bit more on that. I did this talk, I think, I can't remember, a number of years ago, and we had some great questions. So I've tried to keep my slide content down a little bit so that we have more time for discussion around that. Now, can you actually, I've switched over to my slides. Can the slides be projected? So you can see the slides over there, but not here. Oh, there we go. All right. Right, perfect. Now you guys know a few slides. Just remind me, because I just noticed that there's a bit of a delay when I shift the slides and when it actually shifts. So if I start talking ahead of myself, you know why. All right. Okay, so that's quite a bit of delay. There we go. All right, so I'll keep that in mind, about a 5-second delay or so in shifting. So let's go over a little bit about what the prostate is, which is probably not something that you guys are unfamiliar with. where it is located, what's the task of this gland that we have. So the prostate gland, as you're aware, is a male gland. It does not exist in females. It's actually part of the urinary passageway. So if you were to think about starting from the outside, where you start with the penis, the urethra, which runs down the penis, carries through the prostate, which is kind of like, I always call it like an apple, and the core is the urethra itself. So the urethra runs down the center of this core, this apple, and then into the bladder. So they're all one contiguous organ. The cells that line the urethra are the same as the cells that line the inner surface of the prostate, which are the same as the cells that line the bladder, the ureters, which are the tubes that drain the kidneys, all the way up to the kidneys as well. So it's a contiguous organ per se that produces urine. The prostate itself is more of a fertility support organ, really is the way to think of it. So most of the ejaculatory fluid that men produce is prostatic fluid mixed in with some semen, obviously. So it's there to support the semen in the travel through its journey during fertilization process. So as we age and we are no longer wishing to be fertile, the prostate itself probably has some other minor hormonal functions and immune functions and stuff like that. But the majority of the function, as I said, is support as a fertility organ. That's kind of the anatomy of where we were talking about, which is basically going into the urethra, tucks in under the pubic bone, and continues on through. As you notice that the rectum is in close proximity to the prostate itself and bladder, and this is why we can actually check for cancer through rectal examinations. In fact, the majority, about 80% to 85% of cancers happen to occur in the posterior, the back half of that prostate, which is in close junction to the rectum itself. So lucky for us, we have a quick access to feel for cancer in that fashion. There are, of course, cancers that occur away from that surface, and those are the ones that can be missed as well. All right. So diseases of prostate, prostate cancer is one of them, obviously, but more commonly enlargement of the prostate, benign prostatic hypertrophy, or prostatitis, infection, inflammation of the prostate, or other disease processes we often will deal with. How do we go about figuring out what's going on? Well, some of you and many of you may have had a procedure called cystoscopy. This allows us to actually look down that urinary passageway and allows us to actually anatomically view the bladder, the prostate, and the urethra, trying to see what's going on in terms of obstructive symptoms or irritative symptoms. So if there's burning or pain, blood in the urine, difficulty in emptying your bladder, we use this tool to help us look. And when we look down the scope, this is the kind of imaging that we might see. So that little bump in the middle there is actually what we call the verumontanum, and then beyond that is the prostate. So you're seeing you're on the urethral side right now, looking into the prostate, which then goes into the bladder next. All right. So when you have, so in a normal gland, it might be more or less open, kind of like this. But as the gland gets increases in size and gets more obstructive, this is the kind of image you might see when you look down. It's blocking the passageway. All right. That ends up in symptoms of difficulty in urination, slow flow, dribbling, second void, like when you go to the bathroom again. There might be some burning discomfort, urinary spray, all those kind of things, going to the bathroom at nighttime, etc. The reason I tell you all this is because this does not mean you have cancer. It means you have an enlarged prostate. Because what are the symptoms for prostate cancer? There aren't any. There aren't any real symptoms until late in the disease, when there's metastatic disease and other complications of the cancer. So in the early stages of prostate cancer, there are no symptoms. This is why we promote and encourage people to get regular examinations, rectal examinations, get the PSA test done. There are other newer modalities coming out that are also being utilized, including things like MRI of the prostate as well. So the key thing, though, I think the drive home message there is that prostate cancer may present, especially in the early stages, without any symptoms. And that the symptoms that most men experience are usually due to benign enlargement, which is very common. All right, so I'm jumping a little bit ahead, and I realized that when I put the slide in afterwards. I'm telling you a little bit about the positive effects of cannabis, and I haven't really told you about the endocannabinoid system, but I'm going to tell you a little bit about this, and that is a kind of a cool study that was done a number of years ago in which they used cannabis and cannabis extracts to see if they could change those urinary symptoms we just talked about. And interestingly enough, if you look at this slide here, highlighted in yellow, cannabis extract had a strong ability to improve bladder function, up to 38% in this study. THC, which is one of the cannabis components, which we'll learn about in a minute, had about a 33% improvement versus placebo, which was about 18% in this study. All right. So there are indications for the use of cannabinoids in not only, let's say, cancer and other areas of medicine, but this is one of the areas that's interesting that's being studied, and that's something that's kind of an interest for me, which is overactive bladder and pelvic pain and the use of cannabis and cannabinoids. All right. Prostate cancer, very common. Much more, it's 1.4 million new cases worldwide diagnosed, 250,000 new cases in North America and Europe combined. Approximately 1 in every 9 men will end up with prostate cancer at some point during their life. As you get older, the incidence of prostate cancer increases. It doesn't necessarily mean that it is clinically significant, i.e., it's unlikely to change the natural lifespan of, let's say, an 80 or 90-year-old gentleman, as it might a 50, 60, 70-year-old gentleman, right? So the older we are, the more likely we have cancer, but will it have an impact on how long that person lives? Probably not, or less so. The death rate from prostate cancer, and this is the most recent numbers I could come up with, is about 14% of men who have been diagnosed with prostate cancer end up succumbing to their disease at some point. And we talked a little bit about this. It's important because there are no symptoms to do things like the rectal examination, to do things like the PSA testing, MRIs coming to be more popular as a secondary test to do after the first 2 tests. And there are other tests as well, other blood tests and things that are being developed as well. All right. So in terms of treatment, you are very lucky to get lots of great speakers to come and talk to you about different aspects of things. This is just a quick overview. So not every prostate cancer needs treatment. Some cancers are slow growing, and the man will pass away of old age before the cancer gets to be an issue. So not every cancer needs to be treated. So active surveillance is certainly an arm that we use quite often. Basically, this is where we will do serial PSA testing, some rectal examinations, maybe a repeat biopsy, maybe some imaging, CT, bone scans along the way. And we follow this patient along to make sure that the cancer is not getting to be a clinical concern. But we may actually follow that person all the way through without actually treating the cancer. But if we do get to treatments, then of course we have surgery and radiation treatments are 2 of the mainstays that we look at. Surgery has different formats, the traditional open surgery. Nowadays, we can also do laparoscopic surgery. And here in Victoria, lucky to have our new robot, and we can do robotic surgery as well. Radiation treatment, you're going to hear a lot more about it in the upcoming speakers down the line, but there's different formats of radiation treatment, including what we call external beam radiation treatment, EBRT, 3D conformal, where we actually use computers to regenerate images of the prostate gland itself, and then the radiation is focused in a very different directions and angles of that prostate. Brachytherapy, which is seed implants into the prostate itself. There are various different other experimental, I call them experimental because there isn't as much legacy behind some of the newer treatments like cryotherapy, microwaves, etc. So there are other treatments that will probably have some really significant impact on our disease processes in the future. This is just a quick schematic of what we would be doing to remove the prostate. I'm not going to go over this in any detail. I want to make sure that we get on to the meat of the topic, which is cannabis. But it's important to understand that we're kind of in a very exciting era. Not only are there being discoveries about how to treat and manage cancer better, and it's not just prostate cancer, it's all kinds of cancers, but we're also getting very good at knowing which cancers we need to treat, and we're getting good at targeting those cancers in individuals very well, or better, I should say. And this whole area of sort of very personalized medicine is something that's evolving very quickly with the advent of AI, computing services, ability to do tests, do genomic testing, look at what we call proteomics, which is looking at a protein profile within patients. We can take all of this data and we can put it into software now that helps us say, you know what, for this gentleman, for Mr. Smith, and his particular cancer, we're going to start with this treatment and follow it up with this treatment. And finally, we're going to watch him in this way out of the choice of everything we have. Why? Because he has the parameters that meet the requirements that give him the best outcome if we do it this way. So this is really, really cool stuff that's coming down the pipeline and continually evolving in terms of personalized medicine. And part of this personalized medicine is going to be treatments like endocannabinoids or cannabinoids, because this is where we will start to understand that certain individuals express in their cancers express certain proteins or genetic makeup that allows us to target those with specific plant groups such as cannabis. So we'll get into that in a second here. So it's not like we haven't dealt with plants and bring plants into the world of medicine. So aspirin, everyone's had an aspirin at some point. That was from the willow bark. That's where it evolved from. So we discovered aspirin from a plant. And then when we tried to find out how does aspirin work, we discovered the system that it works in. And this is the prostaglandin system that's really well established, well known and taught in medical school. Okay. We also found out from the opium poppy that we can extract morphine. So that's where morphine came from the opium poppy. And now, once we knew that we had morphine, we went to search out how does morphine work in our body, and that's how we discovered the endorphin and the enkephalin systems as well. So this tells us that there's actually systems in our bodies that these plants are actually responding to, right? So this is where cannabis comes in. So cannabis has been around forever, like ever, and used in medicine, medicinally, for a long, long time. And it comes, of course, from the flowering plant, the cannabis sativa and cannabis indica. Sativa be the more popular, the more common one. And just by the way, you hear a lot in the popular media about, oh, I use a sativa strain or I use an indica strain, and sativa makes me feel awake and indica makes me feel relaxed. And none of that really exists anymore. This is just all salesmanship. The reality is that most of the plants we have in North America now are hybrids. They have parts of indica, parts of sativa plant. They've been crossbred and inbred and rebred so often that purebred sativa and indica are almost impossible to find, and usually are found in other continents and in remote locations where there hasn't been a lot of crossbreeding. So when you're at, let's say, a dispensary and the individual's trying to explain to you how much better sativa would be over indica, just keep in the back of your mind that that's probably more salesmanship than anything else. It just doesn't exist anymore. But nonetheless, we discovered cannabis. From cannabis, we discovered Raphael Mashum back in the late 1960s, discovered the active ingredient from the plant that was used as a medicinal component. That was the THC, tetrahydrocannabinol. And that was used, he extracted that, he found out that that was the active component. That then led to doing various sophisticated assays where they radio tagged the molecule to see where it functions in the body and what happens. That led to the result that resulted in us discovering an entire system that existed, that has always existed, and that is the endocannabinoid system. So the endocannabinoid system is a system that is now slowly being taught in medical school, but is like the other systems, like the endorphin and enkephalin system, like the prostaglandin system, already pre-exists in our body, has a normal function in our body, which we'll go over in a minute. And the plant happens to, or when we take the plant and its extracts, we're exploiting this particular system. So if you think about it, it's just like when you are in pain and you take Tylenol 3, which has codeine. Well, the codeine, which is a morphine derivative, has come from a plant, yes, but now works on a very specific pain system, the endorphin system in our body. And so that system already existed. We're just using plants to exploit this system. And cannabis is no different at all. It is also what we use to exploit the system. In fact, use of cannabis goes back, well over 5,000 years into ancient China and Egypt. And in fact, ancient Chinese doctors were using it in combination with alcohol as surgical anesthetics. Dr. William O'Shaughnessy also published a very extensive dissertation on the use of cannabis, which was hemp derived, in reviewing for diseases such as rheumatism, rabies, cholera, tetanus, cramps, delirium tremens. This is going back to 1839, right? So cannabis as a medicine has had a very long history with us. Unfortunately, what happened was somewhere along the line in the United States, cannabis was listed as a controlled substance because previous to that, you could buy it like any other at any drugstore, just like any other drug you would buy, Tylenol or anything else. In fact, Bayer was one of the largest producers of cannabis oils and tinctures back in the day. But then it became a controlled substance. And in fact, if you look back when it was first being used, it was being called cannabis, which is the correct terminology. But when the American government wanted to control the substance itself, put it under controlled substance use, they actually started to change. There's a huge propaganda to change the nomenclature, and it went from cannabis to marijuana. And marijuana is just actually equivalent to a cheap cigarette in Mexico. So it's a Mexican cheap cigarette, and so they wanted to demonize somebody. And if you look back at commercials, it's really interesting. If you YouTube commercials back in the day, there were these commercials about, parents keep marijuana away from your kids. They'll go crazy, and they got these wives and kids running around like they've got the demon in them. And it's really interesting commercials. But anyway, it went through this shift, and then it got blocked out. And unfortunately, as a result of that, because it became a controlled substance, we weren't able to study it. We weren't able to test it out in medicine. And then we had this big void for a number of years where we couldn't study cannabis as a plant. Only now with legalization have we started to open the doors again, where we can now start to study their effect on our human body and how we can exploit this plant to help us in terms of medicines. And you can see the number of publications here that has increased over the number of years. So what is the role of this endocannabinoid system that already exists in our body? So it has it's incredible because it's ubiquitous in not just, it's in just about every mammal you can think about, and some invertebrates as well. It's a very, very basic system that exists. And it controls things such as appetite, so eat. So the way to think about it is cannabis's role is eat, sleep, relax, forget, and protect. Right? Those are kind of the broad categories of the endocannabinoid system's activities, right? And we'll break it down a little bit further as we go through in terms of what this really means. But what's interesting about it is that the receptors, so the actual receptors that exist in the endocannabinoid system that are where the plant plugs onto, where the THC and CBD actually attach to, These receptors exist in two different categories. The first category is called CB1, and these are the receptors that are found primarily in the brain and in the spinal cord and in the nervous system. The other category is CB2, which was discovered a little bit later, and it's primarily found in the peripheral system, mainly along immune modulating organs, spleen, in the white blood cells, etc. And if you think about it, it's very sophisticated, because if you think about it, nature has designed a system, the endocannabinoid system, to allow the central nervous system to have a roving monitoring system throughout our body. So the central nervous system not only has these tentacles and wires that go out to our hands and feet and everywhere else and send nerve messages back and forth, but they also have this free floating system called the immune system that has the same makeup, responds to the same chemicals, the endocannabinoids, but these are a liquid moving through your blood, going into different cells. So it's an incredible system that's been set up where you're combining the hardware and a roving system to monitor how your body functions and monitor bodily functions. It's kind of cool if you think about it. That's incredible. That's an incredible design. One thing that's really, really interesting about cannabis that is different from, let's say, the enkephalin system, so morphine and fentanyl, etc., is that there are almost zero receptors for cannabis in the brainstem. The brainstem is what controls our breathing and our heart rates, our core functions. So the opioid crises, for example, the reason people overdose and die is because they overwhelm their brainstem receptors with fentanyl, for example, and that shuts down their breathing and causes their heart to stop, and that's where you get a death related to that. You could consume a truckload of cannabis, the plant, eat it all night long, and other than throwing up, you will not go into respiratory arrest. So there is a lot of, I guess, sort of myths around cannabis that people don't understand. And one of them is that, cannabis is a gateway drug and cannabis can cause a lot of, toxicity to the body. The reality is that the endocannabinoid system is the most ubiquitous component in our body already. And the plant being applied to that is actually strategic in many ways. But however, there are actually a number of safety features already kind of built in. One of them happens to be the fact that there are no receptors, or very, very few receptors in the brainstem where damage can occur. So it's an interesting component. You can see where it does exist in other parts of the brain there. So that was the CB1 receptor. And that was, remember I said that was a central nervous system receptor. And that slide's popping up again. Yeah. So you can see the brain there, and you can see the different areas of the brain that it exists in. There is also CB2. Remember I said that's the peripheral roaming system, and that exists all over the body. You can see it light up here in different formats, everything from light blue being the lowest amount to red being a higher amount throughout the system. And what's interesting about it is in the central nervous system, we have the receptors that this is supposed to depict basically information traveling down a nerve cell, going from one cell to the next cell to the next cell. That's how we communicate. That's how the brain communicates with our arm, with our mouth, and whatever else. It just sends messages down a pipeline. And so the endocannabinoid system is part of that pipeline. It regulates the information travel on the highway of those neurons. And there is actually, so as we said, the plant uses this system, the endocannabinoid system. However, of course, we don't have the plant in our body. We have natural components. Our endocannabinoids are the things that trigger the cannabinoid system in our body. There's several of them actually. The two most popular ones are 2-AG, which is arachidonoglycerol, and the other one is anandamide. And these two components already exist in our body, and these are the triggers that turn on and off the endocannabinoid system that exists in our body. What's interesting also is that there's a bunch of modifiers things that we already use, and there's more and more research coming out about how they may actually be affecting or how they have their effect on us. So a good example is like ibuprofen and Tylenol. Great for pain. We know how they work because ibuprofen works through the prostaglandin system. However, it also blocks the breakdown of the components within the endocannabinoid system. So it upregulates the pain control zones in the endocannabinoid system. So it has a dual function. It has a function like, for example, ibuprofen would have a function of helping you as an anti-inflammatory, working on the prostaglandin system, but it also upregulates your endocannabinoid system, which also helps you with pain management. So what's interesting about pain and cannabis use is that cannabis use has a dual function. All right. So it not only works in the periphery where you have pain and pain nerves being stimulated, but it also works in the central nervous system on your pain perception. So as you know, great example, my son can't stand the dentist. If the dentist opens his mouth, he's screaming already. Me, I could have a drill bit down there and doesn't affect me at all. Like I will take it without an anesthetic. Why? It's the same, same oral cavity, same teeth, same nerves, right? We share genes together. Why does he have a different pain sensation from me when it comes to this kind of, dental surgery, let's say, right? And that is because part of that pain is not just the real injury that's been happening, but it's also your perception of that pain. And you guys know that, right? You've heard lots of stories about these things. And the reason, and so cannabis, we know, works not only in the periphery, but also on that pain perception through this endocannabinoid system in the central nervous system. Exercise, a runner's high. A runner's high might very well be the fact that we know that exercise actually increases the CB1 receptor expression. The body makes more as you more exercise you do. So you actually get the euphoria built into your own body. That's might be what exercise induced highs are all about. Social play. So there's lots and lots of studies that have shown that people going through trauma in their life, whether it's cancer or loss of a loved one, etc., if they have a big support group, they do extremely well. They do much better, I should say, than those that do not have a support group, who do not have a social support group. How many times have you heard about one spouse passing away and the next one passing away within months because they've lost that spouse's support and that's what they have, right? That kind of thing is very real, and that may be mediated through the endocannabinoid system, because we do know that social play and interaction increases the anandamide, which is the natural stimulant for the endocannabinoid system in our body. So there's things that we don't understand, that we thought we don't understand, that maybe we're starting to understand better, how these things work. Alcohol is known to be a global depressant to the brain, but it also specifically dampens the endocannabinoid system. So that's one of the negative aspects of the alcohol component, for example. And I personally have a theory that I think the placebo effect, we can give a sugar pill to someone and a real pill to the other, and we might get the same effect in some people. I think that that's because we've convinced ourselves on the placebo arm that we're getting the real treatment, and that's being mediated, I think, through the endocannabinoid system. I think that it's a real change happening in the body with the receptors for the endocannabinoid system being stimulated because we have willed it to be so, right? And that might be where people say that there is something to do about visualizing your cancer, about visualizing fighting the cancer. There's been a number of anecdotal sort of case reports of people literally shrinking their cancers through positive thought processes. As a scientist, I kind of used to go, what's that all about? Like, positive thinking to get rid of your cancer? That doesn't make any sense. But now I actually realize that what's probably happening is we're stimulating our own defense systems in our body, like the endocannabinoid system, to actually mediate that process, that positive process, the positive thinking mediating cell death. in cancer cells because we've stimulated a system in our body that's able to do that cell death, able to execute on that cell death. So we talked a little bit already about the safety of cannabis. It's very interesting. There's been a number of multi trials that have been done in terms of addictiveness of different substances, and you can see where cannabis comes in quite low on the addiction scale relative to other substances, including our glass of wine that we all enjoy. So let's keep that in mind when you hear rhetoric out there about, cannabis being a gateway drug, cannabis being addictive. I'm not saying that cannabis is good for everybody. There's obviously good and bad to every medication we take and everything that we do. But let's just keep it in perspective, is what I'm saying. So what's interesting is if you think about it, there's a lot of my colleagues who look at me and go, this cannabis stuff is like it's shaman oil. Like it's good for everything. How can it be good for diabetes and foot fungus and brain cancer? Like, what are you talking about, right? Like, it just makes no sense, right? And you kind of go, well, that's interesting because there are studies that show it helps with diabetes, and there are studies that show it helps with brain cancer and foot fungus too, right? And how is that possible? Well, that's possible because we're dealing with a ubiquitous system in our body that has both the central nervous system in its pathway, as well as the peripheral system, the roving system that it uses. And there's something we call the entourage effect. So what I mean by that is that the cannabis plant is not just one substance. It's not just THC. It's not just CBD, but it has 180 plus components in that plant, some of which have already been found to have benefits medicinally. Some may not. But for example, CBN has been shown to help with sleep. CBG has been helped as an inflammatory. But that's just the those are just the phytocannabinoids. Those are just the cannabis-related things in the plant. Guess what? Everyone knows what cannabis smells like. It's a very distinct smell to it, skunky, whatever you want to call it, right? And in fact, some of our recreational cannabis users will even be able to distinguish different types of cannabis. This is purple kush. This is Girl Scout cookie. This is etc. Right? Like they know the different smells and what properties they would carry. Guess what gives off that smell and everything? It's not the cannabinoids. THC has zero smell. CBD has zero smell. The plant has terpenoids in it and flavonoids. So terpenoids are a different component within all plants. How many of you have smelled lavender? How many of you have thrown it in a bath bomb because it's relaxing? Guess what? That contains the terpenoid lavulin, and lavulin works on the endocannabinoid system, and it's a calming effect in the endocannabinoid system. So it's not because you happen to have thrown, some of that in your bath bomb and the smell is good and you're all happy. It actually has a physical action in your body. You know who figured this out and capitalized on it? Pine Sol. The pine, right, is limonene and pinene, two combined terpenoids that they put in that cleaning agent that is known to work on our endocannabinoid system to give us euphoria and make us feel like it's good and clean and fresh. So they have exploited those smells. So you think about it, when we smell things and that makes us feel in certain ways, how does that work? It works physically through systems like the endocannabinoid system, where you have the terpenoids, we call them, these are the smell components, and flavonoids are flavor components that are real chemicals that we have extracted and can study in a lab that have action on the endocannabinoid system and therefore have action in there. Have action. So it's actionable things that are happening when you're throwing in your bath bomb, right? So this wheel here, look at it. It's spinal cord injury and fibromyalgia and sleep apnea and cancer and my God, this is like a drug. One drug kills everything, but it's not so. It's actually it's actually a bunch of different drugs in one plant. It's 180 drugs just on the cannabinoid side. It's probably another 500 flavonoids and terpenoids on the other side, all combined in this one little plant, right? But and wait a second, we can then combine those things. So, for example, if you take THC and you combine it with caryophyllene, which is what you would find in black pepper, for example, so you will not only get a calming effect, but there's also a very strong anti-inflammatory effect from the caryophyllene. And now you combine those two, and it makes wonderful for injury. For example, if there's been traumatic injury to a body part or something, you have a lot of inflammation. It helps you with the pain, but it also helps with the inflammation. And that's because that plant contains two components that help. Can you imagine the combinations that are available now within 180, cannabinoids and 500, flavonoids and terpenoids? Like, the combination's amazing. Yeah, maybe it does do all of this, but it's probably combinations thereof, not just one drug, right? So, but as clinicians and as scientists, we take a very conservative approach, right? I'm not going to tell everyone to go grind up some cannabis and use that for everything, right? So we have places that we put it into. We have algorithms that we think of when we're thinking of how we manage our patients. So, for example, patients with pain, the Canadian Pain Society has put out an algorithm. Let's start out with, let's start out at the top. We'll try out some aspirin. We'll try out some ibuprofen. If that doesn't work, we're going to try out some opioid analgesics, Tylenol 3, morphine, hydromorphone, etc. And if that doesn't work, then the Canadian Pain Society says now may be a time to try cannabinoids, right? And it's not exclusive, of course. You could combine, the cannabinoids with an aspirin, because as we've seen, there is that effect that they work together as well. And then there's a bunch of fourth line agents and stuff like that. So our thinking is, because I don't want to convey the message that I think that this plant is, the magic bullet to everything. It's not. We're going to learn more from the plant, and we're going to be able to extract more and more information from the plant. But in the meantime, we're going to start to integrate it into our algorithms of care, whether it's pain, sleep, diabetes, cancer, etc. We're going to have space in there to start to plug in our knowledge base as we learn. So let's just talk a little bit about cancers and the roles that the endocannabinoid system may play in cancer. So first and foremost, because there's been such a moratorium on studies and difficulty because it was illegal for such a long time, there hasn't been any good large clinical trials in any cancer arena to show a benefit of using cannabis to treat cancer. Okay, so I want to be clear in saying that at this point in time, we don't have any strong evidence that cannabis can help breast cancer, prostate cancer, glioblastomas, brain cancers, etc. Right? We have building evidence in where we might be able to use it, but we have to be very cautious. And I'm going to throw out the caution by showing you some things. So, for example, in this one study, they used THC, which is one of the components in cannabis. They used THC to treat breast cancer cells in a petri dish. And what they found was at a certain concentration, it killed the breast cancer cells. However, if you added more THC, it didn't kill the cancer cells. In fact, it made them grow faster. So there's something we don't understand fully. It's not just the magic bullet. And so I bring that up because I feel like many of my patients will bring me a study and say, here, look at this, the Rick Simpson oil. It worked for cancer. Rick Simpson oil worked in a very select population of people with Lewis lung cancer. It didn't mean that it worked on every other cancer, and we don't even know the true formulation. But yes, there was a study that showed some benefit in that one particular population. But But be cautious because we don't know the concentration. And so if you use too much, it might make the cancer worse. If you use too little, we don't have that full information. Until we have that information, until we're able to study it more, I think caution needs to be thrown out, right? Colorectal cancer as well has been shown to be responsive to THC. And again, these have been in animal studies, and in petri dishes. What's interesting is with prostate cancer, there's lots of CB1 and CB2 receptors right on those cancer cells. And in fact, not only are there receptors for the endocannabinoid system on these cancer cells, there's more receptors the more aggressive the cancer is. So in the first column, we have benign growth of the gland, and you can see the density of the sort of the brown staining in those benign cells of the CB1 and CB2. As you get to a low-grade cancer, you can see that the distribution changes a bit, but so does the intensity or the number of cells that have it. And by the time you get to high-grade disorganized cancer, prostate cancer, you can see how much more staining there is, more intensity of staining, so there are more receptors. So there's actually receptor upregulation, and therefore we may have a target. We may have a good target in knowing that the cannabis CB1 receptors and CB2 receptors exist and they get upregulated. So as future studies happen, we will be able to target these potentially, one, to either kill those cancer cells, or two, to take other drugs to those cancer cells. Because if we know the receptor, we just take a piece of cannabis, we attach our chemotherapy agent onto it, and now we got a targeted chemotherapy agent because it hits the cancer cell directly on that receptor and kills those particular cells. So that's targeted kind of delivery, and you save the toxicity of all the other cells not getting attacked because they don't have the CB1 receptors at the same way, and it's the same level. That's a potential use you can see that might come down. And we do know from various different animal studies and prostate cancer cell line studies that prostate cancer is responsive to cannabinoids, and it does cause cell death to occur. So there's cannabinoid receptors that we saw in the last staining. And if you add a cannabinoid antagonist, so something that binds to it, an agonist, and stimulates those cells, those cells actually undergo, those prostate cancer cells actually undergo programmed cell death. So they actually undergo apoptosis and they die with the addition of the cannabinoid onto these cells. And this has been shown in various different cell lines. The LinCap cell line is a very, very popular line that's used for studying prostate cancer for chemotherapy, and it has been around forever. And it was one that was shown to respond to it. And what's interesting was it was known, not only responded to the cannabinoids being added and causing programmed cell death, but the actual mechanism is similar to a lot of chemotherapy agents. So the pathway of killing these cells was similar to the pathway taken when you add a chemotherapy agent as well. So these are using various different intracellular pathways, and those were similar. And what's interesting is that you could take and you could add the cannabis onto the cells, and then take and add on something that blocks the cannabis receptor, and those cells would not die. So it kind of showed that it was the actual cannabis acting and working on those cells. So they have done those kind of mix and match studies as well. It happens in a time-dependent fashion, happens within 24 to 72 hours. It induces apoptosis to occur. What it does also is it changes the genetic production of things that make the cancer cell grow. So we know that, for example, the androgen receptor is an important component of prostate cancer, and that's how we in fact treat, not treat, but manage prostate cancer with hormone shots. And those hormone shots work on androgen receptors. It's So when we added cannabis, the cannabinoids were added, it actually decreases the production of these receptors. So it kind of induced cell death in that fashion. The PSA, which is a marker that we used, was affected as well in its production, and various different other components were also affected. So the actual working mechanism was also delineated in these studies. Brings a lot of hope because, I mean, don't forget, this is a cell line and this is done in a petri dish and it's done in animals, right? So it's not ready for human consumption, but certainly the evidence is pointing in the right direction. It's certainly saying that in the next number of years, we may get to the point where we'll understand how to use cannabis to treat prostate cancer, because there seems to be evidence lines that show in a petri dish that it works. Cognitive time. So I'm not going to go to the last study, which was basically showing the same sort of phenomena, because I want to make sure that we answer as many questions as possible. So I just want to kind of briefly summarize the cannabis system that you've learned about this evening, hopefully. So cannabis comes from plant, as does aspirin, as does the opium plant providing morphine and hydromorphone. It has what's known as phytocannabinoids. Two popular ones that you hear about all the time are THC and CBD. By the way, I didn't mention this earlier. THC is the one that's more psychoactive. It's the one that gives us the high. It's the one that gives that recreational users utilize. CBD is not intoxicating. It is not psychoactive. You can use CBD and you can drive and work and do everything because it is not intoxicating. All right. So the plant produces over 180 of these components. CBD and THC are the ones that we hear about all the time. So I use those as examples. Those have equivalents in our body. So those are phytocannabinoids. The endocannabinoids, which are our internal system, have two components, 2-AG and anandamide. Those are the equivalents to those phytocannabinoids. So those happen to work on the endocannabinoid system, which has receptors, CB1 and CB2. CB1 found in the central nervous system, CB2 out in the periphery, along the immune system primarily. Beautiful little marriage between the two gives us control of what's happening, in the periphery through our central nervous system. All right. It has been around for many. So I guess I didn't mention this earlier, but if you look down the sort of the phylogenetic tree, it gets down to like even, the smallest cell organisms have the endocannabinoid system with it. So it's not something that we have developed just recently. It is something that has evolved, I can't remember how far back it goes, but to the smallest organisms and has gone up the phylogenetic tree to humans through and through. So it's a system that's ubiquitous. It's throughout the body and it has a normal function. Some of the normal functions are, the sleep, eat, protect, forget, right? So those are the components it has. And it does that normally on a day-to-day basis. It's a regulatory system in our body, right? But what we're now finding out is that regulatory system has different, because it exists ubiquitously, it may have a positive effect for various management of various disease processes that occur. Because in the end, what is disease? Disease is our natural process going awry, right? Cancer is normal cells that have forgotten how to behave normally, right? Diabetes is normal cells that stop functioning and stop producing insulin. Alzheimer's is normal cells getting plugged up and the myelin, and components changing within. MS is myelin sheath loss, etc. Right. So disease is really normal things going awry. So what we do understand is that using cannabinoids, we may be able to exploit either the reparative process, and there are some studies about neuro regeneration using CBD. And we may be able to also exploit the system as a as that immune surveillance, that cancer surveillance that goes on in our body, and exploit it, ramp it up to kill cancer cells as well, right? So that's kind of like the big picture overview. There's lots of fine components within that, but I'm going to open it up to discussion, and that I think we can go over it that way.